Well, thank you very much for that very kind introduction, Dr. Fenster. And it's great to be with all of you this afternoon to discuss AI access and equity in rail and remote imaging. I think this presentation follows Dr. Mendez's presentation very well. We heard some of the challenges surrounding providing healthcare in our rural and remote communities, and imaging is particularly challenging due to some of the advanced techniques that and the infrastructure that just isn't available in many of our rural and remote communities. I have no conflicts of interest to disclose. So as Dr. Mendez highlighted, there are persistent inequities in rural, remote, and indigenous communities. And some of these aren't easy problems to solve. They're major structural barriers. We have chronic technologist shortages. It's difficulty recruiting, it's difficulty retaining technologists in these rural and remote communities. This results in long travel distances for patients to travel. In Saskatchewan, we have patients traveling literally hundreds of kilometers to Saskatoon, to Prince Albert, for even a simple ultrasound, for CT, for MRI. And these challenges are more difficult because many of these are northern communities. They're weather-related challenges. Many of these communities are only fly-in communities or available access by an ice road. And there truly is limited access to advanced imaging because of the cost of these systems. We have major advanced imaging modalities such as CT, MRI, PET-CT in our major centers, and it's simply not available in many of our rural and remote communities. So this results, as you might expect, in delayed diagnosis, higher acuity at presentation, preventable health disparities. As a solution, at the Virtual Health, we've worked towards multiple solutions in healthcare, particularly in imaging. And our vision at the VHH is that AI-assisted imaging, combined with robotics, remote operations, and intelligent automation, is creating a new distributed model of care where geography no longer limits diagnostic access. So with this key point, I'll highlight a few examples of where we're going towards this AI-enabled imaging ecosystem. Using AI, using robotics, remote operation to deliver high-quality diagnostics anywhere. And I'll highlight specifically two imaging modalities there, ultrasound and CT. And in the next 15 minutes or so, I'll go over some of our work with telerobotic ultrasound, AI-blind sweep ultrasound, moving towards intelligent robotic ultrasound systems, autonomous scanning, lesion detection, characterization, all autonomous with AI. And with CT, I'll dive into a remote operation model, which will be applying for lung cancer screening, and specifically highlighting some of the solutions we've been exploring, solving difficulties, say with contrast administration, when we deploy a CT system in rural and remote communities. So beginning with telerobotic ultrasound, as Dr. Mendez highlighted, this is now a technology we've been working with a few years now. We now have telerobotic ultrasound systems in 5 communities. And with this technology, a sonographer, a radiologist at the virtual health hub at a central site can manipulate an ultrasound probe, and all motions of that probe are replicated at the patient's site, wherever it may be, say 100 kilometers away, via a robotic arm. And with this technology, sonographers, radiologists have two-way video conferencing with a patient, with a site assistant, full robotic arm control, rotation, rocking, tilting of the ultrasound probe, and can view and manipulate ultrasound settings through the ultrasound video. Here are some of the sites that we've currently been deployed, and these are now clinical sites. We've moved from these being research pilots to now providing a continued clinical service in these communities. And how we got here, we conducted clinical trials for obstetrical imaging, for abdominal imaging. Here are some of the results I'll highlight specifically for OB ultrasound. Comparing the mean duration of scanning for detailed exams, we can see very similar exam times between telerobotic and conventional exams. When we look at our main biometric parameters, we see very high inter-class correlations between standard biometry and biometry obtained using the robotic ultrasound system. When we look at specific image adequacy for specific exam types, we see very high image adequacy for specific types of exams for first trimester, OB for limited obstetrical for renal. We do continue to have challenges for second trimester OB ultrasound. So as a policy decision, the VH8, we've determined that those patients who do require a second trimester exam would best be served through an in-person exam. So because of our clinical trials, we've been able to determine what works, what doesn't work in terms of diagnostic adequacy for robotic ultrasound. We've conducted an economic evaluation of robotic ultrasound, and as you might expect, what's cost effective is really going to be depending on the size of the community, the volume of the ultrasound exams which are performed. So in this study, we compared a few models of ultrasound imaging, a model in which all exams are performed using telerobotic ultrasound, a model combining telebody and itinerant sonographer who travels to the community on a routine basis, an itinerant sonographer only model, or that baseline model in which all patients need to travel for all exams. And what we found is that that hybrid model, combining robotic ultrasound with an itinerant sonographer, was cost effective for these certain community characteristics. Communities with a population of at least 2,075, a distance at least 350 kilometers away from the nearest ultrasound, and a specific population eligible for publicly funded medical transportation. So this gives us a sense on what is the most cost-effective model of providing imaging care across these various communities. We know that, as for example, in some of these communities, the infrastructure requirements for robotic ultrasound are just too great. And particularly when we think about our low and middle income countries and the collaborations we have in Tanzania and Ethiopia, we need to explore other solutions, complementary solutions to provide OB and other types of ultrasound. We've explored AI ultrasound through AI analysis of blind sweep videos. So in this model, a community health worker performs 9 sweeps through the abdomen, as you can see here. And through these semi sweeps, basically about 15 seconds each or not, if we concatenate these videos together, use a convolutional neural network, there have been multiple studies now which have demonstrated high accuracy for predicting gestational age. This is one of these studies, recently published in JAMA by a collaborator, Jeffrey Stringer at University of North Carolina at Chapel Hill. And in this study, 400 participants, novice users, using this AI-enabled device, estimated gestational age as accurately as those done by sonographers with a 0.2 day difference. So essentially a non-inferior to conventional ultrasound. So this is just the beginning of what is possible through this blind sweep method. We're collaborating to expand this approach for assessment of fetal position, for amniotic fluid volume, for placental location, for fetal anatomy, based on blind sweeps. Really, this estimation of gestational age, as you know, is just one small piece of an OB exam. And we're working towards expanding this approach to these other parameters of the ultrasound exam. We're working in 3 different research settings at Regina Tertiary Hospital in Saskatchewan. We're really going to look at the diagnostic accuracy of expanding from gestational age to estimated fetal weight, and there's other parameters like fetal presentation, amniotic fluid volume, placental location, for example. We're going to implement this technology in our rural and remote communities. We'll really be able to look at this from an implementation science perspective. What are those best practices to ensure culturally safe care for our rural, remote, Indigenous communities? We also have an established collaboration with a center in Tanzania. And as you can imagine, many similarities between Tanzania and rural and remote communities in Canada, but also some cultural differences. So again, we're going to examine both the diagnostic accuracy, but what are those best practices when we apply this technology in diverse settings? And so some cross-project themes across each of these projects: validation of AI for diagnostic accuracy, culturally responsive and context-sensitive implementation, prioritizing community health system partnerships, and really cost effectiveness from health system and societal perspectives. What I've described is the Melody system. which we've worked on in collaboration with Tech from France. And we also expanded collaborations to additional companies, which have developed 5 degrees of freedom on robots. And with this 5 degree of freedom robot, we're able to expand beyond rotation, rocking, tilting, and eliminate the need for that patient-side assistant to control gross movements of the robotic arm. And as you can imagine, this is still a teleoperated system, and our sonographers are performing these exams. And because of the number of exams they're performing, this is providing a large data set of training data. All of those fine movements we can capture. And if we capture this data, we'll be able to use that data for training a model for autonomous ultrasound scanning. Really combining these 3 different layers, combining that robotic platform that can position and move the probe with AI that recognizes anatomy and pathology in real time. Of course, these computer vision models have been developed in many different contexts. We just need to apply it now for this specific context. And applying quality assurance algorithms that assess whether images are diagnostics, really being able to leverage this data that we're acquiring on a daily basis with our robotic ultrasound exams, and using that to train a robotic platform for autonomous ultrasound scanning. So we envision an end-to-end platform from localization of imaging anatomy, say localizing the right flank to visualize the right kidney, moving towards image sweeps, being able to specifically, number one, detect a lesion. Once the lesion is detected, characterize that lesion with measurement and Doppler imaging, with giving it a Bosniak score in the case of cystic renal lesions, for example, and then moving towards structured reporting. Again, we're doing some work there in terms of moving beyond just detecting whether findings are present, but then applying it to a large language model to actually create an AI-assisted report through passing that prediction on to an LLM. As Dr. Mendez highlighted, ultrasound imaging is just one of the imaging modalities that we use on a daily basis that's critically needed in our rural and remote communities. And with our mobile imaging pod, we'll be able to expand our capabilities from ultrasound in the north to CT to remote X-ray. And critical here, it's not just the technologies in the mobile pod, it's that remote operation through the remote operation hub at the virtual hub. When we speak with our communities, when we look at disease prevalence across our province, across Canada, we see the critical need for lung cancer screening. Lung cancer, it's the number one cause of cancer death in Canada. Over 50% of lung cancer cases are diagnosed at a late stage, and we know the poor prognosis associated with lung cancer. And this is particularly even worse in northern communities. We have higher burden of lung cancer in rural and remote communities. There are persistent access gaps. When our provinces launch lung cancer screening programs, there are patients who are left out just because of proximity to geographic proximity to CT scanners. So with this mobile pod, we're attempting to bridge these screening gaps because we know lung cancer screening works. There have been multiple studies that have demonstrated a 20 to 30% mortality reduction with lung cancer screening. When we think about lung cancer screening, as radiologists, we see lung nodules. We see lung nodules all the time. And most of those lung nodules are not malignant. And when we think of applying this technology to our northern communities, these false positives are particularly concerning. Say we have the pod in Stony Rapids, one of the most northern communities in Canada. We detect a lung nodule, and then as a radiologist, we recommend follow-up in 3 to 6 months. Well, that follow-up in 3 to 6 months is particularly challenging for a resident in a rural and remote community. Because if the pod isn't available in that community at the specific time, that still might mean travel to a southern community. So that's why that precise characterization of a nodule right at the time of screening is going to be so critical. We've explored models to improve our classification of lung nodules beyond what radiologists are able to perceive in lung nodules. This is a study we published in the Journal of the American College of Radiology. where we applied a deep learning model, a machine learning classifier, for classifying nodules as benign or malignant. And with this tool provides basically a probability of malignancy, basically what we call a malignancy similarity index. And based on the malignancy similarity index, we'll be able to guide whether that nodule can be safely dismissed, that it's benign, nothing to worry about, or whether that patient should proceed directly to PET-CT or biopsy or a shorter-term follow-up. And the results here, oftentimes when we think about sensitivity and specificity, there's a trade-off. But with this model here, we are able to boost sensitivity by 25 to 117%. And this is across 3 different cohorts. First cohort, Luxon from the National Lung Screening Trial in the United States. A cohort from Saskatchewan, from Mill University Hospital. And third, a cohort from Washington. And across these 3 cohorts, sensitivity was boosted by 25 to 117%. While also increasing specificity by at least 17%. And as you can imagine, if we're able to classify lung nodules with increased specificity, we'll be able to detect lung cancer sooner. We're not requesting that the patient return back for screening in, say, 6 months, just to see whether that nodule has increased in size or whether it's stable. So for those lung cancers, we were able to achieve early diagnosis in 42%, based on the NLST study. We've also looked at what are the health system implications of this technology. This is a cost-effectiveness analysis. We developed a strategy for applying the information that we gather from such a machine learning classifier. This is just a simple classification system where we took our AI output and basically used a single threshold, either high or low risk. And in this strategy, those nodules that are deemed low risk by the AI tool were downgraded to a category 2 in the LungRADS categorization system. LungRADS is the standardized reporting system for lung cancer screening. So basically, if the AI system determined that lung nodules to be low risk, we could safely say that the patient could return for screening in 12 months, no interval follow-up required. But for those nodules deemed at high risk, at minimum, in this strategy, the patient would be recommended for follow-up CT in 6 months, or a shorter-term interval follow-up, or biopsy or PET-CT, depending on the LungRADS categorization. And if we set our threshold, a set point, to match the sensitivity of the average of these 6 radiologists from this study, we are able to demonstrate a cost savings of $72 per patient screened. And this is all comers, all patients participating in a lung cancer screening program. And when you think about the volume of studies that many centers perform for lung cancer screening, these are significant cost savings for health systems and potentially cost savings for our remote communities when we deploy this system in the north. One of the challenges, though, with CT is that intravenous contrast is required for diagnosis of multiple pathologies, both vascular and non-vascular pathologies. And the difficulty with intravenous contrast is it requires physician supervision in order to administer contrast. So when we think about northern communities, oftentimes there isn't a physician available to supervise that contrast administration, particularly when we think about our mobile imaging pod, in which we simply won't have a physician traveling with the pod and won't have that ability to have that physician supervision. So new strategies in order to gather the benefits posed by contrast enhanced imaging will be critically required for our remote communities. And we've explored AI models to bridge that gap between non-contrast CT and contrast-enhanced CT angiography using deep learning models. In this study here, we applied a diffusion-based model, a Brownian bridge diffusion model, to basically translate a non-contrast CT to a contrast-enhanced CT. Work has used a similar technique using generative adversarial networks, using variational autoencoders, and there are, of course, challenges using GANs or VAEs for this technique. But now the technology has progressed such that diffusion models are very promising for image-to-image translation tasks, such as going from non-contrast to contrast-enhanced CT, or modality to modality tasks, like moving from a CT to an MRI. And I'll just dive into the results of this study here, demonstrating some qualitative results here. A slice-consistent Brownian bridge diffusion model here, shown from an input, the non-contrast CT, to a contrast-enhanced CT. So, of course, you can see very nice contrast enhancement of the thoracic aorta, of the cardiac chambers here. In this example here, we lose some definition of the proximal descending aorta. So this we would call a bad example from the model. But all of these examples from the SCBBDM model, single slice Brownian bridge diffusion model, do outperform other state-of-the-art models, SiteSand, Pix2Pix, selected here on this slice. And you can see very close fidelity to the ground truth CTA. When we look at our quantitative metrics, peak signal to noise ratio, SSIM, and MSC, again, we see superior metrics with the SCBBDM model. And then we did also a small scale multi-reader, multi-case study where we had two readers assess 30 cases here that of the ground truth CT angiography studies compared to the synthetic contrast enhanced CTA studies. And you can see that in most cases, non-inferior results for anatomical detail, contrast specification, background noise, overall quality, and confidence in diagnosis. But we actually see a difference here. In reader 2 is the question, how clearly are key anatomical structures defined? And the reader 2 here actually found that the synthetic images more clearly defined anatomical structures. And then you can see in this example here that in many of these examples, the SCCBDM model actually gives better contrast specification than our ground truth images. So here we demonstrate that the diffusion-based approach outperformed current state-of-the-art GAN-based approaches. They reduce the need for iodinated contrast, safer, more accessible, particularly when we think about the limitations of contrast administration in rural and remote communities, and even our major academic medical centers. Our next steps will be to apply to pathologic cases, external validation, moving towards implementation into the clinical workflow. So from these examples that I presented here, with regards to robotic ultrasound, to AI blind sleep ultrasound, moving towards an end-to-end intelligent robotic ultrasound, using AI to perform autonomous ultrasound scans, thinking about some of the remote operation CT and our strategies to improve diagnostic quality and efficiency with CT. It really comes back to our vision for the Virtual Health Lab with regards to imaging. AI-assisted imaging combined with robotics, remote operations, and intelligent automation is creating a distributed model of care where geography no longer limits diagnostic access. I'd like to thank many of our funding agencies, CHR, Saskatchewan Health Research Foundations, and Patterson Children's Hospital Foundation, industry collaborators, as you can see here, academic collaborators, which are highlighted here as well, because it really is a team effort. We value our industry and academic collaborators, and really through this collaboration, we're able to move imaging forward for some of our most underserved communities. So with that, I'll leave it at that, and I'll turn it over back to you, Dr. Fenster and Dr. Mendez.